Now I can't move forward. So as I said, a busy night tonight. We've got quite a lot to get through. So really, without further ado, okay, on the keyboard, beautiful. Thank you. I'd like to introduce Fahir. So Fahir is an RN who trained and worked in Kenya for 5 years before coming to Australia 13 years ago. Fahir is currently working as an RN with the Mata Refugee Health Service and is a member of the G11, the Community Health Consultants. She's a newly qualified midwife and she's hosted several education evenings to encourage health awareness and literacy among Somali Australian women in the Brisbane community. As a mother of 4, Fahir knows a thing or two about raising children, and so she's going to give us some community perspectives on raising healthy kids tonight. Thanks, Fahir.
Thank you. Good evening to everyone. Thank you for the good introduction. Tonight I'm here to speak on community perspective on raising healthy kids. When I was initially told to do something about healthy kids, I started thinking of all the things we know about healthy kids, healthy eating, exercises, all those little good education, housing, shelter, which are really important. But then I started thinking on a refugee perspective, on our community's perspective. What does this really mean to us? We know that a healthy child, is a child where there's physical, mental, intellectual, social, and emotional well-being all together in the absence of disease. Coming to a new country is not easy. It's very stressful, and it's stressful to the children too. So I started looking up some literature and started talking to a few people in my community, and I talked to a few friends of mine about it. And we came up with a few things. I won't be able to talk about every challenge that parents go through when they're here, but I've come up with a few of them. And I'll start with grief and sadness and loss. A lot of children leave their homes, come with their parents to these countries. A lot of children leave their countries because of war, because of political instability. And the parents, families, everyone, when they're told they're leaving the war-torn countries where there was no safety, there was nothing good coming of it, food was a problem, health was a problem, everyone gets excited. Everyone gets really excited, and there's hope, there's opportunity, there's excitement that you're being educated, you're going to be looked after, you're going to have good health, your children are going to be okay, and all that. But as soon as we come here, and people from refugee backgrounds will agree with me, there's the hope, the happiness, the excitement slowly starts fading out. Because now, in place, you start experiencing grief, you start experiencing sadness, the loss. Maybe these children were exposed to trauma, they were exposed to things they could not handle at that age. They've lost family, they've lost friends, they've left their friends, their families behind in the situation that they know was really bad. So this is really hard for the refugee children. And families are really, really struggling with it, to come in terms with that. And it's not just the children who came here as refugees. The children who are born here go through that too, because they don't have their grandmothers, their aunts, their great-grandmothers, their uncles, or some of them don't even have their dad here with them. So that actually really impacts the relationship families are having with their children, and it leaves the children in emotional withdrawal. They can't talk to anyone about it. They can't tell anyone what they're feeling. The parents are very busy trying to look after them, but they're not listening to them. They're worried because of language. They want to make sure that they are reaching the level another child in Australia is, taking them every day to school, doing everything each person needs them to do. The school needs something, other educational services need them to do something. The health services need them to be taken for immunizations all the time, for appointments. And the parents rarely give time for the children to talk. So it really, really affects their connection. This disconnection can lead to the children sorting other ways of finding happiness. They start going to drugs, finding bad friends, and they end up not listening to their parents, and we know what happens when that starts. The other thing I would like to speak about is the struggle with language barrier. We all know that children learn languages pretty fast, quicker than adults do. My daughter can speak even Japanese, and I can't even speak any word, but because she learns it at school, she gets it. Children forget their mother tongue mostly because they spend a lot of time outside home. They learn the English language quicker than their parents do. And the parents, in turn, give them a responsibility they're not able to do. And this is really affecting the refugee families in many cases because parents ask their children to do the interpreting for them at school, even at the GP. They do fill up forms for them. They do the Centrelink forms for them. They do everything that the mom or dad cannot do because of English language. So this has led to the children thinking that they have a lot of power above their parents and they can do what they want. And because the parents are scared of what the child is going to do, they don't say a lot. They don't talk about why you're doing this or what are you using this for. They let the children use the internet as much as they want. They don't know who they're talking to, who they're involved with, and it's a real struggle. I recently heard of a story of a child who missed school for so long. The teachers kept sending messages on his mom's phone, but he had diverted the whole messages to his phone. So the mother could never know he's not going to school. He woke up in the morning, went to school, but he never reached school. She only came to realize this when she found a letter in the mailbox, and someone had to read to her asking, "This says your son is not going to school." So that's how hard it is for a refugee parent who does not speak the same language as their own child. If parents come from transit in many countries, some parents come from their home country, go to another country before they come to Australia. Their children are born in the home country. For example, people coming from Ethiopia, they come through Sudan, maybe Egypt, and a child is born in between Egypt and Sudan or in Sudan or Egypt. That child is bound to speak Arabic. You found the mother cannot understand her own child because they don't speak the same language. So the struggle is a long one. Then we have lack of knowledge, which is a big one because parents do not understand their rights and the rights of their children. They think that in the system, the children are just right. That's how they've been told. They've been told that you can't do anything to your child, you cannot discipline your child. The children have a way of manipulating parents. They know what they want and how to get it. And it's really affecting relationships. It's making the parents really, really struggle a lot. And it's affecting our teenagers. Our teenagers deliberately do mistakes. They decide to do all the wrong. They go into the wrong gangs. They do all the wrong things knowing that my mother cannot discipline me. And as refugee community, many of who are here, if you're refugees, you'll agree with me, our discipline is different from the Australian mainstream discipline. So the children are not with us in that way. They're not disciplined. And so they just go away and do whatever they want to do. And it's a struggle. From a refugee perspective, parents are really, really struggling. And you cannot have a healthy child if you cannot even direct your own child. You don't understand each other. You don't know your rights as a mother. And the child thinks that, well, I have all the rights. You need to give me internet. You need to give me school, everything. And yet you won't even find your children going to school the right way. So that's one of the major struggles, and the consequences is that we're losing a lot of children in our communities to drugs and alcohol and illicit drugs and mental problems. We've got a number of children who are already in the mental institutions because of drugs. We're struggling with the other thing is with the different parenting styles. I've touched a little bit about the parenting styles. So the punishments, the discipline, everything is very different. We Africans mostly believe that the child has to be smacked, to be disciplined by smacking them, so to make them understand and not to do the mistake again. It's not allowed here. I don't know how it works, but the children know that. So, and it's quite hard for the parents. You find parents just sitting there and asking you, what am I going to do? I can't do anything to my child. They're not trying to get out of that comfort zone and try to learn how to discipline their children in another way. Then we have, back home in the community, we had the child is a community, is being brought up by the whole group, not just the mother or the father or the family. It's a whole group of people looking after these children, and that made it easier to discipline children and to avoid things that would bring problems. We have single parenting as a big issue, and we're getting this because when our children reach especially the boys, if the father figure is not around and they reach that stage, they need a father, it's hard to teach them the right things. And we find that apart from all the other things children do, our children end up making the really wrong choices and ending up in jail. From there, they come out with different issues, psychological issues. They need counseling, they need help, which a lot of the people in the community don't actually know how to get it. So tonight, if this is one thing we need to go away from here with, is to help parents from refugee countries to understand that there's a system out there that would be able to help them. Then we have stigma and technology. I've touched on technology about children doing everything for their parents, but stigma is all about children doing the wrong things and parents hiding it. Parents don't own up it, and children are in jail because of drug abuse or stealing or something, and the parent will actually say, my child is on a holiday, instead of asking for help. And that's why I said if there's something the professionals need to go away with, is how to help these mothers and fathers with children. In the last bit, I'm just going to talk about what I think would be a consideration. So I think education sessions for new arrivals about this system, their rights, the rights of the child, and what could be done if this was, I think this would be good if it's actually delivered to the parents when they are newly arrived in their skill sessions and all that. Help families access proper services for health, counseling, youth services, instead of giving them diagnoses. Sometimes behavioral issues are given big diagnoses and parents just give up. And so if you tell a parent that they have a child with the diagnosis and start medicating that child, they will end up not getting the medication because we don't believe mostly in those diagnoses. So you need to educate the parents about it. Encourage parents to give children time to spend with their friends and make parents feel like their friends are welcome at home. Refer parents to parenting educations. If you can refer the parents to PPP and such services, and actually if we can advocate for such services to get interpreters and involve them to help parents learn how to look after their children in this country, that would be really good. Lastly, educate the parents to give adolescents, the young, time to spend with them. It's really hard for us as refugees because we have to support our families here and we have to support our families back at home. But we still need to get this message given to parents that you need time to spend with your children, yet even if it's 20 minutes, to just give it to your child every day, and it would make a big difference. Thank you for listening.
Thank you, Fahia, for those really valuable insights and I think important considerations for all of us as healthcare providers. Fahia is going to join us on the panel again later to talk through some cases, so that would be wonderful. Our next speaker tonight is Catherine Eichmann, who's going to talk to us about the impact of learning English as a second language. Catherine is the senior speech pathologist for the adolescent and child inpatient unit at the Queensland Children's Hospital and works with children with severe and complex mental health and communication issues. She's previously worked in a community clinic with a high culturally and linguistically diverse population with limited own language literacy and English language proficiency. In collaboration with the University of Queensland and combined with her previous community clinic experience, Cathy developed a clinical handbook for working in a mental health framework for complex, culturally and linguistically diverse cases and their families. Thanks, Catherine. Okay.
Okay, so I'm just going to try to provide a brief sort of outline about what might be a normal pathway for acquiring English as a second language, to think about some of the factors that impact on L1 being your first language and L2 maybe being English, but it might be other languages in between. Some sort of key factors or red flags of things to look for that might highlight when this process isn't going quite as well as we would hope. And some guidelines for working with English as a second language, and just some general impacts and considerations. And I guess if we think about language development, there's lots of things that are consistent across any language that you use, that we develop speech sounds, that the language develops in a consistent pattern of you develop understanding before you develop your speaking, that it's learnt through your attachment system and through your relationships with your primary caregivers. It's a developmental process, it's needs driven, and that there are, to a large extent, some critical periods of learning where it's really important that you grasp some of these language components, and you're going to find it much more difficult to do that past some of these critical periods. I guess there are some similarities that we've been able to see for learning language depending on whatever that language might be, and there's certainly quite a lot of studies that show that vocabulary size is roughly similar for a certain age, be it whether you speak English or Spanish or Vietnamese or whatever. You're very likely to have a vocabulary size of a similar amount of words that you understand for that particular age. We know that from a grammatical point of view, again, for all languages, that you start out with one word and you build on that. But we do know that there are very different rules about how you use that grammar, how you mark different things that are important and salient in language. And certainly in English, the use of the t, or he walked, indicates that it's past tense. So for us, that's a very salient thing that may and not at all be present in another language. And in another language, they might actually have, say, in Cantonese, tones, so that the tone with which the thing is said is of significance and impacts on meaning. We also know that from developing a storytelling kind of perspective, that globally there are some similarities in the way that we do stories. There's usually these similar kinds of ideas of a beginning, middle and an end. In some cultures there's also an extra added on one, that's the forever after, sort of looking into the future and the beyond. So there are some consistencies that kind of help us to think about language learning. And I guess there are other factors that are really quite important to think about. It's the timing of exposure to each of the languages and in what stage of development they're at, how much that language they've acquired and when they're needing to acquire another language. The quality and the quantity of the input is quite critical. There's a lot of studies. A good example of that is if we look at low SES people who are English speaking, then the number of words that they hear and they use is significantly lower than a middle class family. So the quantity actually does matter as well as the quantity. There might be structure of similarities but there might actually be quite big structural differences in the language. The environment in which they're learning this, the broader community supports for that language, and the types of languages that they're being exposed to. And I guess what really got me interested in this area is that I work with many children who've got language impairment, and many of the risk factors for poor language learning align very closely to similar kind of risk factors that our culturally and linguistically diverse children and young people would experience as well. So that's what made me think, how come we're not thinking more about the language needs of these young people that we see? And I guess we know that that learning more than one language, that having an equal proficiency in each language is actually quite rare. That the total vocabulary that a person knows, that's putting all of the languages they know together, only counting, if they know one word in 3 different languages, we only count it the once, but counting all of those can give us a sense of their vocabulary size, which will give us a bit of a window into roughly developmentally, where is this child's understanding of words sitting? And we also know that the typical acquisition of a second language frequently results in differences. So there are these processes that occur, and they're common kinds of things where there's this interference where they will switch between using their first language, using words of English and first language structure, using English structure and first language words, so switching things around. There's quite a bit of literature around particularly that first, did I go back way too far? Yes, I did. Okay. In that very first 2 years, it's not unusual for children when they first come here to have up to a 6 to a 12-month period where they actually don't speak outside of their family home, and that they can actually present as mute in their classroom setting, and that is not an unusual thing to see, and it doesn't equate to a language disorder. It's part of this transition in learning language that's really a very complex thing for a lot of our young people and our children. And I guess when we think of bilingualism, and most of the classic literature will talk about bilingualism that's very based on a European or a South American idea where people are exposed to those languages simultaneously and get fairly even kind of exposure. That is not the kind of exposure that our young people are getting. They have what we call this sequential learning. They're exposed to their first language, they might be exposed to another language and another language in camps, then they're exposed to English as well, and they actually often transition from competence in their first language to lots more competence in their second language. And they're not truly bilingual in that sense. And I think, it makes so much sense that some of this stuff leads to some of the confusion and the difficulties for parents who are still really working in first language and have really good first language, and they've got a young person who's transitioned to being dominant in English. And it does create huge challenges, and how do we work with this? And I guess the other kind of thing to keep in mind, that it's actually a really lengthy process to learn English as a second language, and that it takes about 4 years to understand about as much in English as you understand in your language, but you will still be behind your same age peer. It takes longer, about 6 years, for that to be similar. So if you were to formally, but if you were to look at their language skills, after about 6 years, if they're developing okay, their understanding will be very similar to an average Australian-speaking child, but it takes longer for that expressive component, so up to 10 years. It's a very long time, and a long time in a child's education, when not only are they having to learn this language, but they're also having to transition and learn more complex language as we go along. And I guess some of the things that kind of really looking for those sort of differences and thinking about whether it's a language difference rather than a language disorder, and is the pattern consistent with what you would expect for a child who's learning English as a second language, or is it a pattern that suggests that they've got a language learning disorder that may indeed have been present right from the beginning before they started to learn another language or transition to English. And all of those kinds of things about the frequency with which they're exposed to English, how many people in the family speak, what languages are spoken in the home, how much are they spoken in the home, are really critical factors. I've been surprised by the number of times when I've asked that more specific information to find that actually dad's got a different first language to mum, and what they use at home might be another one again. And English is the one that their young person is choosing to use the most. So it's quite a complex picture. And I guess one of the risk factors for not being good at learning language or learning English as a second language is if you can't acquire your first language well, you're much more at risk. And it's obviously more than just the language. There's whole lots of other factors associated with that. So one of the best indicators for good outcomes is acquiring your first language well. And I guess reinforces. Okay, doesn't want to move. Okay. So supporting first languages, children certainly benefit from learning two languages, and it's really important to encourage that. And I think the thing that was really hit me in the face working clinically with this population, that it was really important to reinforce with parents that if you're predominantly using your language, L1 at home, use L1 at home. Use L1, use that to teach your child well, and use that language as the mediator to learn English, and not fall into the trap of feeling that you need to use broken English or poor English structures to try to make sense of the world. And that they can use that first language to help learning in their second language. And certainly what definitely assists is having the support of an interpreter and really doing very detailed questioning to look at their pattern of language learning. So I've often used an interpreter to ask lots of specific questions about learning language and what they did when and what kind of things how they use their language to get a pattern to show what that might be, whether they were developing quite okay and whether we've had a change with learning English, or whether in fact they were a young person who struggled with learning language all the way along. And I get that we need to know these things to know what is the most appropriate way to help this child or young person move forward educationally and in their community. And that the obvious kinds of things that we would always use for learning any language are still the same, using exposure and modelling, repetition, and using visual supports to help that along the way. And I guess just as a nice positive kind of aside, there is quite a lot of research that says that being bilingual is actually a really helpful thing, that it has at least a neutral but probably a positive effect on your learning and development. It strengthens your phonological awareness systems, particularly where the languages are a bit similar. So that's your ability to listen for sounds and words. They're more creative and have better complex problem solving, do better when they're older, and there are some cognitive advantages in terms of that being able to switch attention, because when you're having two languages you have to switch between the two. We do know that there's the overall, so we've got this capacity to look at receptive vocabulary and be able to get a sense of, is this child developing in a totality where they should be or not? And it can also help us then to go, we've looked at language L1, L2 or L3 or English, and out of that can determine, oh, actually they've got heaps of words in L1 but not much in English. Or it might be the complete and utter reverse. They've got a lot in English and actually don't have much in L1. Really useful information about what language should I use when I'm trying to work with this young person. And I guess I'm not going to go through, but there is a little handout if people are interested, and I have my email contacts, but it's just got those basic things that we went to, but it's also got a little bit of information about what would be normal sort of developmental vocabulary milestones, just to help people have a bit of think around that as a bit of a guide. Obviously there is a degree of individual variation, and where this kind of tool for me has been very useful, it's helped to identify a young person who at the age of 14 had a receptive vocabulary of a 5-year-old when you put all of her languages together. So she clearly had a language struggle that was beyond learning English as a second language. And I've seen other young people where you put the two together, it's about what you would expect, and what they have in L1 and what they have in English is very similar. So they're developing in a pattern that you probably would expect for their age. And I'll leave those there. Okay, thank you.
Thanks, Catherine. Next up we have Amy Burkett from the Queensland Program of Assistance for Survivors of Torture and Trauma. Amy is the Clinical Services Manager at QPAST, and she's a clinical psychologist and has worked with refugees and asylum seekers in varying capacities over the past 9 years, and often joins us at these events, so thank you, Amy.
Great, thank you. Sorry, I'm a bit short, things are a bit high. It's all right with the screen as well. So I'm just going to talk a bit about, we've touched on already around trauma and the impact of trauma on children. So I just want to unpack that a little bit more in terms of how it will present and how you can best support these children and young people that you might be working with. So I guess, we're not often just working with the individual, but we're working with the family unit as well. So torture and trauma impacts individuals, families and communities. And it's really at that kind of base level of having safety undermined. When core attachments are disrupted, it can create that sense of loss, mistrust and maintain vulnerability. Trust and dignity and the value of life itself can be questioned by trauma survivors as a result of experiencing and witnessing horrific acts of violence. Shame and guilt emerge in survivors and is perpetuated by ongoing loss and separation from loved ones. So that's that whole family system that we come across as well. But specifically, refugee experiences for children, I think keep in context that within the refugee experience, traumatic events are rarely an isolated occurrence. So often people that we work with, it's not just going to be one thing that they've experienced in their lifetime. Children may not have been directly exposed or witnessed traumatic events, but are likely to be impacted by their parents' experiences. And I think that's also useful to keep in mind that often when we work with and understand the experience of children, they don't have a coherent narrative of what has been experienced or why the family might be here as well. And it can also sort of often create discontent within the family as well. You know, if there isn't understanding of why mum or dad had to leave and then, well, why are we here? Why are we in this situation? And these traumatic experiences often occur during key developmental periods. So as a result, it's already been mentioned tonight, but attachment, skill development, physical maturation, growth of self and identity can be disrupted as well, and how that then plays out for these children and young people. So these are, I'm not going to go through all these things because I know a lot of people in this room are familiar with these types of things, but this is just a list of some common experiences that children might have experienced prior to coming to Australia. And why I've kind of put them here is for you to have as flags in your mind. So sometimes in the next few slides when I talk about some of the things that you might observe that people present with children, young people, it's having these flags behind you that these may have been things that someone could have experienced, these children have experienced. And this is not, there's plenty more things that people have come across, but these are very common. I did also want to add that the experience of offshore detention for a lot of children that we're currently in varying capacities you're going to be coming across or have already, because I think it's really important the impact that this is having on their development and how we can best support them moving forward. So many children have experienced offshore detention, so a lot of families being transferred from Nauru, so a lot of those kids have been there for up to 6 years. It's had significant impacts on development and often inability to establish healthy attachments. So whether that's with, a primary caregiver or in a wider context as well. Limited or no experience of formal schooling, experiences of significant bullying, parents with diminished emotional capacity to respond to their emotional and physical needs. And a lot of them have witnessed self-harm and suicide attempts of adults, adolescents and other children. And they're still in that real sense of space of uncertainty and unsafe. So I think that's just useful to keep in context with these other things that we hold in the back of our mind when we're working with these young people. So trauma impacts children in many different ways, but these are some of the key things. So they will often develop an expectation that bad things are going to happen to them. They might have difficulty forming relationships with people. So even thinking about that in terms of the context of a health professional or in a school or wherever it is that you're working with these young people and some of that difficulty forming healthy relationships. Have difficulty managing or regulating feelings and behaviours, and have difficulty developing a positive sense of themselves. So again, this is just a bit of a list of things that you might see in front of you in terms of working with a child, in terms of how they start to present. So, again, I'm not going to read through everything, but withdrawal, lack of interest, poor concentration, repetitive thoughts about traumatic events, crying a lot, disrupted sleep, tired all the time, lack of trust of adults. And I think this is kind of useful in terms of, when we see these things and this is what we might observe and what gets presented, it's thinking back to some of those other things around, what might be the history behind someone, what might be their previous experience that this is now coming out in the present for them. And I guess settlement, because of these experiences can be impacted in many different ways. So often, as I sort of said, when it's impacted not just at the individual but the family system as well, is that often several members of the family have been victims of or witnessed torture and trauma. There's ongoing loss and concern for family members overseas, experiences of feeling unwelcome by the host community as well. Roles within the family can definitely become altered. Children may, become the burden of having to communicate with service providers on behalf of parents. Exposure to new values and opportunities can create generational conflict. Parents may lose their protective and nurturing roles due to their own mental health. Loss of employment, financial and social status can cause difficulty feeling confident and connected to the community. And for asylum seekers, there's that ongoing sense of not belonging, lack of certainty, safety, and constantly being in that kind of state of limbo of what's going to happen. And that really impacts people being able to kind of settle and connect with the wider community. So a few things to keep in mind supporting these children that we're working with is acknowledging that the child isn't bad. Often when we sort of see, thinking back to that list of presentations, sometimes that's how a child can get labelled and they're having a normal reaction to abnormal experiences that they've had. In every interaction, trying to keep these kind of key trauma-informed principles in mind, of safety, trustworthiness, choice where possible, collaboration, collaborating with peers, with other service providers to support these young people, and empowerment, which is really useful thinking about in terms of parents, empowering them in supporting their child. and in really involving the parents as much as possible with the child's care and giving them sort of education and support in that space that you're working in. Avoid using the child as the family interpreter. I know there's times where it happens, and of course it does, but thinking about the impact that that has on the child, you know, sort of in a medical context, hearing these things about mum, or in different contexts, hearing different things, or actually the quality of what's translated and interpreted back. And this is, you know, in terms of different settings that you're in and being conscious of kind of the setting that you're in and with interactions that you're having with children is having some things that are going to feel comforting for them. You know, so is it okay that you've got sort of some soft toys, you know, things that they could hold and try and help regulate with, or sensory and tactile items? Because sometimes, you know, we're all working in different contexts, but these things can be difficult to talk about or difficult to hear for young people, or the system they're in is very overwhelming. So anything that can help them to regulate is really important. And I guess a really key thing is safety. And while these examples that I've got here, you might sort of look and go, that's not going to apply to the context I'm working in, a lot of these things can. And they may sound quite simple when you're looking at them and you're reading them, but the power that it has when, you know, providing sort of consistency, you know, if you're in a health setting, meeting with that young person in the same room every single time that you meet with them, and how much that can be really useful for them to create safety, to help them regulate, to understand what's going on. So, you know, predictability, structure, routine, consistency, repetition, flexibility. Again, are you going in with sort of, this is all this information I want to gather, well, actually understanding that maybe I'm not going to get everything I need, and that might be over several sessions that I need to gather that information, and being flexible. You regulating, you know, remaining kind of calm and regulating yourself is going to support that young person as well. Being aware of the space in the room, and, you know, sort of sometimes we don't think about these things, but if we're in a really large room, how overwhelming that can feel to someone when they're not sure what this system is that they're stepping into. And ask the child what helps them feel safe as well. And this is just a great, and a lot of people, you know, would be aware of Bruce Perry's work, and often this is sort of more from that kind of learning space, but I think it's just a really good diagram to think about, and it applies to so many different contexts. If you're in a situation where you're working with a young person and for whatever reason, because we've spoken about lots when they might become dysregulated, if you start to go in at reasoning with them, that's not going to be useful. That's not going to support them, and it's not going to help them. So you need to kind of go back down to the bottom, support that regulation, help with that self-soothing, connect, and then reason as well. Okay, so it's just really useful to keep in mind if you're not getting anywhere with that kind of intervention. I just want to mention as well, dealing with disclosures of traumatic material, particularly with children, and to kind of, this is where some of that, you know, co-regulation is useful. Listen and respond with acknowledgement, normalise it, you know, affirm that it's acceptable to have these strong feelings, and acknowledging bravery and being able to talk about these things. Trying not to act negatively is your response. I mean, often some things we hear, they're really awful, but just being aware of your reaction to that as well. And discuss the possibility of appropriate referrals, but also what you can do to support throughout that referral process. And is there sort of a warm referral process that you can do? Contact, collaborate with that referring agency. What support do you still need to provide to the child or the family in the meantime? And just a few things to remember, you know, the refugee experience can have a really significant impact on settlement, and don't make assumptions about a child or a family's understanding of common systems that we work within. So the school system, the health system, what does it mean? You know, what is break time in school? You know, going to parade or different things that it's called. A child might not have any context to what that means. So just sort of being aware of those things. A lot of families still don't have any certainty about their future and limited access to support services. So in your work, when you're doing and you think this is time for me to refer on, is having an awareness around what's their history, what's going on, are they asylum seekers? They may be limited in terms of services they can access. Families that have had experiences of offshore detention may find it really difficult to trust and engage with service providers. So keeping that in mind, establish safe relationships and interactions by being predictable, clear, reliable, offering choice, flexibility, patience, and following through on things that we say and we agree to. And I think finally it's kind of having an understanding around someone's prior arrival history, around what they might have been through, helps us to make sense of what someone's presenting with to then support them in the future with their growth as well. That's me. Thank you.
Thank you, Amy. Next, we have David Leavitt joining us. So David Leavitt is the Director of Paediatric Medicine and Dermatology at the Queensland Children's Hospital, and he's also the lead paediatrician at our Mater Refugee Complex Care Clinic. David believes integrating refugee children into Australian communities revolves in large part around schooling, which is trauma-informed, and we often talk about the importance of cooperation between health, mental health and education in achieving the best outcomes for children. So David's going to share with us some of his insights tonight. Thank you, David.
Hi everyone, thanks for inviting me. As Rebecca said in the introduction, the refugee experience directly affects schooling for children from refugee backgrounds in Australia. And I don't mean to tread on the toes of any educationalists amongst us, but the Australian education system has yet to evolve to meet this demand. And my thesis is that if health and education work very closely together, we can overcome that and ignore the fact that powers greater than us, don't quite see it the way we do. The effect of being a refugee or an asylum seeker is very well documented now, and some colleagues of mine in Sydney did a childhood trauma questionnaire survey and found that 63% of children were positive on those surveys, which is not surprising. A very important document, if you haven't read it already, the Australian Health Rights Commission, run by Gillian Triggs, interviewed a large number of people in detention, and the impact was amazing in their document. But the one that already was mentioned by Amy is the fact that children were exposed to mental health and self-harm, and that's had a big impact on the children we see who have come from that environment. The impact of trauma intergenerationally is very important as well, and you've sort of got snippets of it already, but even perinatal PTSD in a mother, and it doesn't have to be in the refugee context, has a long-term effect on maternal-infant bonding. And mothers struggle to find or have emotional availability, and that sort of leads on to insensitive parenting, and there's some references there. The consequences have been documented really nicely by Faria a little earlier, and I won't go through all of those, but it is really important for us to realise that almost 60% of refugees in Australia are under 25, and many are born in refugee camps and have very little education as the baseline upon which we're working. The differential diagnosis that I, as a paediatrician, I'm not a mental health expert or an educationalist, but as a paediatrician look at are PTSD, post-traumatic stress disorder, ADHD, which overlaps, autism, which is a common one, which is flagged, intellectual impairment, which you have to consider in any child at all, but any child in a refugee setting who is struggling at school, a lack of learning experience, which is such a big part of many of the refugee journeys, language issues, which have been discussed by Kathy. And of course, you have to consider other mental health diagnoses, not just the couple of boxes that we all, education and health, try to push everyone into by chopping off their arms and legs and squeezing them into the box. PTSD is a really important one, and I feel really bad that over time I think I've misdiagnosed a lot of people with ADHD, autism, etc., who have had a traumatic experience and PTSD. And it was only in 2013 that DSM, for those who don't know, Diagnostic and Statistical Manual for Mental Health Disorders from America, which is what we use in health and education, but not in mental health necessarily, divided up PTSD into over 6 years and under 6 years. Over 6 years was always there, but under 6 years was new and was trying to look at developmental concepts in trying to diagnose PTSD in younger children. Both groups have intrusion, specific intrusive thoughts, avoidance of stimuli, alterations in arousal. In the PTSD under 6 years, they've tried to make it a little bit more developmentally appropriate. And arousal and reactivity and avoidance of situation, which are often things that we see in the community and particularly in school, become a real issue. For those who don't know, DSM-5 defines ADHD as inattention and or hyperactivity impulsivity, but it must occur in two settings, and this is exactly what they say. It must occur prior to 12, it mustn't be due to another mental health issue. But the issue with it is it must be in two or more settings. So if mum says everything's hunky-dory and the school says nothing is hunky-dory, then it's probably not ADHD. And the vice versa, if they're an absolute angel at school but not at home, then it's again probably not ADHD. But what we know is that the two, PTSD and ADHD, overlap. And it's almost indiscernible in my experience many of the times. Irritability is in both, excessive motor activities in both, concentration difficulties. You can see how hard it becomes. And I go back to what Faria said about labels and diagnoses, you know, those comments, because I feel worse and worse about the job I do in many ways, because I feel more and more painted into a corner in trying to label so that we can do something for children. Impulsive behavior, exaggerated startle response. Now, again, I don't want to tread on the toes of our educationalists, but when you read about how you can work best with trauma-informed care, curriculum which is accessible to all students, safe and supportive school communities, looking at and addressing social and emotional needs, really improves outcomes significantly, and it needs to be a systematic approach of the whole system. But what we know is that ESL is often poorly funded. It doesn't label well enough to get all the funding like autism, and many of the people are from non-literate communities, or they from oral communication cultures rather than written learning, which can often then confound the learning experience. And there are many communities where special education is deemed to be a punishment rather than a help or an assistant. for the individuals. The other problem that we have is how do you do a cognitive assessment on someone whose first language is not English? All of our cognitive assessments are based on English language, and what we know is that cognitive testing should be culturally bound, and this is from the absolute gurus in immigrant health at Royal Children's Hospital in Melbourne, particularly Georgie Paxton. You need to try and use interpreters, but the problem is our cognitive assessments are not normalised or standardised to be used with interpreters. So I've done it once or twice, but I've done it specifically to get an outcome, not because I've thought I've achieving a real assessment of the individual that I was doing. And I think cognitive assessment is a whole quagmire for all of us. The difficulties at school, as you know, which lead then to visit to my office and an attempt to find a diagnosis, are the fact that prior schooling is very poor. There's lots of very limited education, and Amy and I are very aware of the Nauru cohort who were exposed to education, but it was so brutal and they were treated so brutally that it never they never got an education and spent 6 years, formative years, without an education. There's education in English in people whose language is not primarily their L1 is not English. There's that transition from Milpera type environment into mainstream where things become incredibly unhinged often. So what are the solutions that we can do? And that's really hard. We really need a new government with a different funding model that doesn't look at diagnosis, but looks rather at functionality. And that's all we need in pediatrics, and therefore everyone else needs as well, you know, education, mental health, etc. What we want is a system which looks at your functionality, and I was quite hopeful that the NDIS would achieve that for us, but unfortunately we're struggling still even then with the NDIS. It's a little bit better probably than the Queensland system, which is very diagnosis-based. And by doing the diagnosis-based, we limit the number of children, you know, even with the fact that, you know, specific diagnoses will get you some funding. For example, if you've got Prader-Willi, tick, you've got the box, you're in. But if you've got a similar genetic condition, not called Prader-Willi, but on a different part of the same gene, you get nothing. And it's just a bizarre system that we really need to work as much as we can. We need new referral pathways. And I can't stress enough that we need health and education to work very closely together. And I'm very proud, Amy and Kathy are with me on Project Echo, and I don't know if any of you are interested, but Project Echo is a system that's running out of Queensland Children's Hospital, where we have a panel of people such as Amy, Kathy, we've got a multicultural mental health worker and myself, and then we beam out to, we would like schools, PHNs, kindergartens, so that we can work together to try and get over this hump of needing to deal with deal with a specific diagnosis. So if anyone's interested, we can talk afterwards, but look up Project Echo and the Queensland Children's Hospital, because I do think that's a starting point to get us all talking together and working together and bypassing the stupid way that we try and diagnose children. So that's all that I had to say. Thanks.
Thank you, David. I think David's right. The more that we can talk together and communicate, the better we can do for all of our patients and students and community members. I'd just like to thank again all of our speakers tonight. I get the opportunity to speak to you at the Mater all the time, and I've still learned so much. So thank you very much. I really appreciate it. The second portion of our evening tonight is going to be made up of a panel discussion. So I'd like to welcome back all of our speakers, but we have three new panellists to join us as well. So I'll just introduce them. Leanne Allen. Do you want to come up? Does everyone want to come up? Leanne is a clinical nurse consultant for community child health with the Browns Plains and Inala teams. She's a registered nurse, registered midwife and lactation consultant, and has completed a Masters of Nursing majoring in paediatric child and youth health. Leanne has been working in the community child health sector since 2003, and prior to this she worked as a midwife for approximately 15 years. So I think people in Browns Plains and Inala are very fortunate to have Leanne. We've also got Kenny Duke, who's been in the multicultural sector for more than 13 years. She specialises in settlement and youth with a particular skills in business management and human services. Kenny currently looks after the community engagement, community hubs and youth area for Access Community Services, which includes MyQ, the youth arm of Access. And Kenny is also the Queensland representative on the Executive Committee for the Multicultural Youth Advocacy Network, which is a peak body for multicultural youth as the Queensland representative. Oh, sorry, I said you were the Queensland representative. And then we have Kim Shembry, who grew up in the city of Logan. And she is currently the principal of Richlands East State School. Since 1994, Kim has been both a teacher and a teaching principal in rural and remote settings across northwest and southwest Queensland communities. And she is joined by Elsa Demore, who's the ESL coordinator at Richlands East State School. Has been working there for 14 years and really working, I think, with people from a refugee-like background, children from a refugee-like background throughout that time. So we've really got a wealth of expertise on the panel as we work through our case tonight. Thank you. Okay.
Guys, I was just going to say as well, just to kind of help us keep to time a little bit, we might save questions for the end. Hopefully we should have sort of 10 to 15 minutes at the end to take questions. So if you can just jot them down as we go, and we'll work with our panel through the case. So just bear with me for a second. So basically our case tonight revolves around a mum, dad and two children. Darian's 6 years old, and sorry, is that all right? Sammy's 15 months. They arrived in Australia 2 months ago. Just a minute, chair, because otherwise... They arrived in Australia 2 months ago on a 200 visa. They were originally from Iran and are of Kurdish ethnicity, and their religion is Sunni Muslim. The family, I thought this was interesting in terms of what Catherine was saying, speak Farsi, Kurdish, Turkish and basic English at home. They've been attending classes in English classes in Australia. Mum, prior to coming to Australia, was a hairdresser and a beautician in Iran and completed high school, and she's currently pregnant with her third child. Dad was working as an electrician in Iran and had completed high school and was attending technical college and has attended technical college. They're now living in a 2-bedroom flat in Oxley. So I guess this family have come to be under our care as part of a refugee health assessment just after they've arrived. So during that first appointment, a number of things were raised for the younger child, Sammy, the 15-month-old. So obviously we went through a lot of questions, comprehensive kind of examination, but the things that Mum was particularly worried about related to nutrition. So when asked about that, she sort of said that Sammy really ate much the same as the rest of the family, but she did mention that sometimes he gets a bit constipated and that worried her. When we spoke about language, Mum said that Sammy was speaking 2 to 3 words in Farsi, seemed to have appropriate gestural communication, was babbling. She wasn't too worried. In terms of behaviour and discipline, Mum had asked a few questions around this, but she noticed that Sammy does have frequent tantrums, but that's pretty normal for a 15-month-old. I was reflecting on this case. I have a 15-month-old. But she often, at times gave him the iPad and he seemed to sort of settle with that. So it seemed like a good distraction, particularly, when you're trying to get to lots of appointments and that kind of thing and not wanting to disrupt people around. Also, I guess when we asked about sort of kind of gross and fine motor skills, as we often do, we ask questions about, how, can they hold a pencil, do they play with blocks, all those sorts of things. And interestingly, Mum sort of said, I'm not really sure if he's able to hold a pen or scribble or stack blocks because they're not really toys that we would ever have played with at home. And again, that question around, does he attempt to feed himself? Mum sort of said, well, really, kind of dinner time is so fraught. I really just feed him as best as I can to try and make sure that he's getting fed. Again, something that resonated with me. So we thought we'd just start, Fahia, if you're happy, would you mind just perhaps commenting, particularly I think with your experience working as an RN, doing these refugee health assessments and also as a community representative, how might we approach these sort of refugee health assessments and some of these issues here in a manner that is culturally sensitive?
I'll start by making sure that the mother is comfortable. I'm guessing that we've already started the health assessment. So I make sure that the mother is comfortable and give her whatever she needs. Maybe ask if she needs some water, give the children some toys to play with. Discuss with her, ensure that you gain some rapport and trust from her. Discuss with her that you're not going to judge her parenting or talk about what she's doing. Just make sure that she understands you're there to help her and to find out ways to assist her with Sammy, 15-month-old. Try to make sure that she understands why she's there. Give her a chance to tell you her whole concerns. Listen to her. Do not interrupt. Sometimes when people are talking, non-English speaking people especially, we kind of just go tell a big story before we come to the point. Make sure you actually listen and give her that time. And then when you try and find out what Sammy does, if Sammy plays with the brother and if he's active in the house, find out, she says that he has constipation and they eat, the whole family, the same food. Without being insensitive, try to introduce questioning around what kind of foods they actually serve on the table for the whole family. Remember, this is a 15-month-old and could not be able to digest some of the foods. Maybe the foods they're having is not, maybe it's spicy, but that's how the food is. So you try to go around this, trying to be very sensitive about it and talk to the mother and ask questions in that line to make sure that she knows what she's feeding Sammy is good. Sammy's stomach can handle it. And then try and educate her on the foods and the balanced diet, educate on how she can do, maybe puree the fruits for Sammy, maybe soften the vegetables, maybe it's just the kind of food they're eating, and make sure that Sammy's mom understands that you're not out to get a behavioral diagnosis for her child. She shouldn't be scared. Ensure that she knows you're there to help her. Make sure that she knows that you are only trying to give her more options on how to help Sammy.
Thank you, Fahia. I think, yes, really, I think what I'm hearing is just it's so important to take the time to build that rapport and trust and really understand the story. Following that initial appointment, we, as we often do, completed some screening pathology as part of that refugee health assessment. And when Sammy and his mum came back for their second appointment, a couple of things were noted. So Sammy was noted to be very iron deficient. And also had a low normal vitamin D. Mum wasn't too worried about the iron deficiency, but was quite worried about the low normal vitamin D because this is routinely given to infants in Iran and hadn't been available to Sammy in the last couple of months. I guess this prompted a little bit more of a conversation with Sammy's mum, and I think this often happens, as we talk more. We get the details, I think, that Fahia is sort of talking about. But it turns out that Sammy, in reality, probably does struggle a little bit at meal times, loves milk and biscuits, and probably does have that quite a bit. He is also having a lot of toddler formula because Mum really felt that this was had been shown to be really important for toddlers in terms of ensuring that they were getting adequate nutrition. So he's definitely still using that. He'll also drink a bit of strawberry milk, soft drink, juice, but generally will only take that from a bottle still. So Leanne and David, I thought that the two of you, perhaps Leanne, if we start with you, could you have any reflections, I guess, on that scenario?
Thank you. Yep, certainly have. I think initially what we would do within child health is try to make the family feel as comfortable as possible being there. We always use interpreters for families that don't speak English or where English is a second language. It's always offered. I think for us to begin though, what we need to do is a full health assessment. First of all, after we'd explain what our service is, because the family's understanding of health and health supports may be completely different to what they're used to, and there may even be some fear associated with that. So it would be just reassuring them what we do within our service. It's confidential unless we have concerns. We work closely with GPs. We're nurses, and we work in a multidisciplinary team. So we basically just support or talk about the services that Child Health offer. Initially, we'd probably begin with doing a full health assessment on Sammy, just to get a bit of a grounding for how well he's doing in terms of his growth and his weight and his developmental profile as well, because that may impact on what he's doing in terms of his diet and what he's able to take, getting a good understanding even of what's happening orally. If he's got any teeth decay, that may impact on his comfort for eating, that may, or any motor, low motor tone, or anything that may impact on his ability to chew, that could also impact on the food that he's eating. The other thing I'd be mindful of is what the family food looks like, and the sorts of their understanding of good nutrition, what they're used to eating, perhaps in their homeland or where they've moved from, and what they're eating now, what they're aware of, what's available in supermarkets, and whether they can actually know how to cook the foods that are available. So it's an understanding that as well. So we'd be looking at exploring, we can see some issues with Sammy's diet, that's for sure, but really mindful also that we're not here to make dramatic changes all at once. You know, the families have had a lot of change in their life, and we really want to work with them and in partnership with them, so those changes will be slow, may very well be slow, but it's kind of chipping away, giving them a better understanding of good health and nutrition for Sammy and the impact that would have. Certainly Sammy's diet has a lot of sugar in it, and so it would be even exploring what good health and nutrition looks like, and the sorts of foods that could be offered for a little one of his age. Look at what family foods they're eating now, and how we could perhaps slowly introduce some of those family foods, more fruits and vegetables, and meat if they eat meat. But again, that may be very slow, because if Sammy's not used to eating those foods, then it may exacerbate the issues that are there around his behaviour as well. Yeah. Also looking at perhaps talking to the parents about letting Sammy explore the foods himself, to normalise him self-feeding. Thinking of anything else there?
Yeah.
Also about formula, that just recommend that if formula is not required for children over the age of 12 months of age, but also look at his drinking out of bottles, and offer alternatives in terms of cups, using a cup instead.
Yep. Beautiful. Raj?
Just briefly, the low normal vitamin D is normal, so I think we've got to decide on our normal values and then stick with them. So the point being that I wouldn't treat low normal vitamin D. I think that's okay. But the iron deficiency in the diet, firstly, you have to take a really good dietary history, and my experience is that with an experienced child health nurse or nurse in a clinic like our refugee health clinic, those dietary histories are much more useful to me sometimes than a more removed dietitian history, because it's in context of what we're dealing with. I think in the short term we can treat the iron deficiency, which in itself then improves eating and cognition and compliance, and in the long term we can look at improving the diet, just slowly and steadily. That one's not urgent, but in a 15-month-old I'm always worried with iron deficiency, because I think we've got more and more evidence that that's not good for the developing brain, and it's something we can do quickly, and in 3 months we can have a good result while we work on all the other stuff we've talked about.
Our next slide, I think, Leanne, you've probably already come to it a little bit, that there was some reluctance on mum's part in regard to a referral to child health services, and I think you really touched on that already, really about trying to explain to the family, you know, what is on offer, and the confidential nature of that service, and I guess the sensitivity in which you'll approach some of those issues. Is there anything you particularly wanted to add to that, or?
Whilst the appointment is for Sammy, I'll probably also towards the end of the consultation talk about mum's impending new baby, and the way we could support mum, because there were concerns raised there about how the other two children would cope with a new baby and how we could continue to support mum through home visiting, if that's what she would like. But we certainly could, we've got services there available for her. Also that because we work in a multidisciplinary team, we can either refer mum to see our early intervention clinicians with support with parenting, as well as working closely with GPs and if allied health teams, if referrals there were required. We always work through the GP though. We also use, where we can, we try to use handouts and that are in the language, the first language of the family, if they're available.
A little bit more about mum and her pregnancy as we progress through the case, but I think just what you're really describing there again is that really holistic approach and looking to care for the whole family, not just the child. So thank you. To move a little bit on, I think that there's so much more to talk about in regard to Sammy, but his brother Darian, who's 6 years old, also I think was, when they first came in for that refugee health assessment, mum raised some significant concerns around Darian. She has been struggling quite a bit, not in terms of language so much. She described that sometimes he kind of mixes his English words into Farsi sentences, and sometimes he can get a bit frustrated and angry about that. And interestingly, I thought again, listening to your talk, Catherine, the family had really been trying to kind of speak to him in English prior to him coming to Australia, so he would have some English. The school hadn't noticed any concerns, but at this stage, really, he'd very recently arrived and he was getting some ESL support. But she had asked some questions around behaviour and discipline. She felt that Darian had had some real difficulty following instructions. She said that he got bored quite easily and could only really stay on a task for a few minutes. Any task really, but the iPad was the one that he could actually concentrate on for much longer. And so again, often he would spend significant periods of time using an iPad, and she found that sometimes there were tantrums on transitioning away from that. The school had noted that there'd been difficulty for him sitting on a mat or at the desk for any period of time, difficulty in terms of completing set tasks or transitioning to a new task. And again, if they tried to take the iPad away, that there could be some significant sort of yelling and sort of throwing himself to the ground. And mum reported that she tried to manage that as best as she could, but at times that would result in her shouting at Darian, perhaps smacking him and sending him to his room, and that generally he would kind of come out after that and sort of seem fine, and there wouldn't be much more talk of what was going on. So I think this is probably one of those, this is really complex, and I think really complex for any family trying to raise a 6-year-old. So, Catherine, I thought we might start with you, and if you were able to perhaps comment a little bit on some of those, that information around language and again how that might be impacting on behaviour, and then we'll really delve into this with the rest of the panel. Thank you.
Yeah, well, it is a complex process, and he's 6. And his exposure to English has been through whatever mum and dad knew, which was probably broken English and not well constructed. And through good intentions, they're actually using a language system that they're not particularly competent with. I'd be encouraging them to go back to use their own language and really build on his language skills in their language, because that's going to get them the best outcome in the long run. And he is only 6, and if we were talking about an average Australian English-speaking child, they're still learning language skills. We're learning language skills all of our lives, but he's still in a critical learning period for language, and it would be great for him to acquire that best in his first language and then build on that and use that to build his English skills from. And we know that any child that's got any difficulty expressing themselves, then often the first thing they will use is physical behaviour to show that, because if you don't have the words, you use your body. And that in some ways that would make sense that he's using his body to do that. And because language learning, again, is very dependent on your relationship with the other person and their exposure, and this little person's experiencing some degree of unavailability of his parents now. They've got massive things that they're adjusting to, and he's trying really hard to adjust as well, but in the context of perhaps having parents who are less available and are actually not using as much of the language that he perhaps has more competence and comfort with as well.
Sure. I think one thing I'd probably take into consideration, which we've said, is they've only been here for 2 months. So I think that needs to be taken into consideration around sort of supports and what we're putting in place and waiting to see shifts. That's not a long time. I think the other thing that comes to my mind is, which we haven't spoken about, is what their refugee experience is. And, you know, we get indicators in they're Kurdish but have lived in Iran. That's already giving flags around, you know, possible persecution. So that's what I'd be interested in as well. You know, what is it that kind of some of what we're seeing playing out? Yes, it's settlement, it's a new environment, but what also has he been exposed to, what the family's been exposed to, mum and dad, what's filtering down, that kind of thing. And does that give us some indicators around what he's demonstrating? But I think also the other thing that I would be really quite interested in is what the previous sort of response for mum or dad has been to sort of some of these behaviours. You know, is it just, and you know, you might have mentioned it, but is it just now that this is what he's presenting with? How has he presented previously? What's that kind of, you know, attachment and parenting been like early on? Because I think that's really useful to take into consideration as well. Can some of that be applied now in this context?
So again, I think we're really coming back to really trying to understand and get that story in more detail. David, I wondered if you would have any comments around some of the behaviours that we're seeing here and how you might approach exploring them in more detail, as Amy's saying.
I think the biggest thing we've all discovered over the years is time is a really important part of it, together with a nurturing environment and understanding environment. Excuse me. So I think 2 months in, we've got to be prepared to give it time and support as much as possible. And we've got to, my job, I think, is to lock the doors of MRCCC until more time has gone under a pass before I get involved, certainly from a health point, medical point of view, and be pushed down pathways that I'll regret later. And I think that the important thing is time, and I think it's a school community that can build a trusting relationship with this boy. I would like to see, and we'll ask the educationalists, how you can be a bit adaptable and perhaps treat the child like a autistic child. And I say that only in the context of having a bit of flexibility, a timeout mat, you know, an environment where you can allow the child to be a little less structured, sitting in a desk, trying to concentrate, struggling with language, and having that flexibility, I suppose, is what I'm suggesting.
And I guess we've already had the hint from mum that his exposure to educational type tools has just not been likely their experience. So they've not had colouring paper or pens or had stories read to them. All those sort of prerequisite things that other children have before going into an educational system are all very unknown.
Thank you. So I think what we're hearing from everybody is that we probably do need to spend a bit more time with the family and also the school to understand more what's going on and support the family as much as possible. So we've got Kim and Elsa here to perhaps have, if you'd be happy to reflect on what might be going on for him at school, that would be great.
I suppose from a school perspective, we are seeing iPads coming in as more of a soothing tool, more and more with kids, all kids coming from a trauma background mostly. The parents that we work with on a daily basis don't want to see their children distressed. They fiercely love their children, as I'm sure Darian's mum and Sammy's mum does. They want to do the best for their children. So when Darian does come to school, he's going to be bombarded with lots of sensory overload of lights and sounds and 80 children in a playground and 3 spades and 3 buckets. So when he becomes overwhelmed, he's unable to explain. We all know to us that if you just give me an iPad, I'll be fine. So we've got to unravel that as a school. We've got to get the parents in, and that's what we do. We have Elsa, we have our guidance officer, we have our social worker, we have a whole team of people that basically come running to the door of Darian's classroom to support him, to support his mother, but to also support the teacher and the teacher aide as well, who's in the prep classroom. So we have to keep all stakeholders in mind. And I suppose as a school, because we come from an education background, we do end up being a bit of a nuisance and banging on the door of our lovely colleagues in health because we want to strive to get the answers to help him quickly as we can. Because we have a little guy whose first year of schooling, we want that to be really positive for him, and we want schooling to be positive for mum and for dad and for Sammy eventually down the track. So first and foremost, we do build those relationships with our families. We do a lot of talking and a lot of listening. And then we try to gain as much information as we possibly can and put in a plan that will do the best that we can with the resources that we have.
Just to add to that, on enrolment, this family would already get to know myself because I would do the enrolment. We have a list of bilingual aides, teacher aides, that we employ that would assist the children. We don't have any Farsi speaking at our school, but we certainly have Somali. We've got Arabic and Tigrinya speakers, along with the others from Vietnam and Samoan speakers as well as bilingual aides. They help enormously with all our bilingual children. Tea services is used quite a lot. And most of our staff is very well versed into how to handle a situation, or they are now become more trauma-informed because of the push with Education Queensland towards trauma-informed schools. We've done a lot of work with regards to that at the moment and upskill staff into how to deregulate a child that may not fit into what they may want to see in a classroom. So a lot of deregulation activities or soothing type of things are given to our teachers to help. Yeah.
Thank you. I think my background is a GP, and I think so I understand again, often we do have those conversations with schools, and I think it always works best when we actually stop and talk, and perhaps we're not looking at paediatric referrals and those sorts of things at this stage, but sometimes knowing also the supports that are available to us in the community is also really important. So I might hand over to Kenny, who might be able to give us some advice around some of the supports as well.
Yeah, so in terms of community support, for us,
it's really important to look at soft entry approaches to working with the family. Obviously, like Amy said, it's the timing of how new this family is and giving them those social connection and support. So seeing whether they have the community linkages already with their own communities. I don't know how many of you have heard of community hubs, but we have community hubs, not in this specific region, but we have families that are travelling from different places to both our Ipswich hubs and our Logan hubs. And why they have been so successful is because they are really focused on early childhood. We really encourage places like, services like child health nurses. They come and outreach there. We've got an occupational therapist. We have a refugee health nurse that raises awareness. We have different parenting programs, and they're very much around culturally responsive. So we've even partnered with QPAST in making sure that those conversations are being had with community, and they're feeling it's coming from a very strength focus in terms of building on and understanding systems. I think it's your community centres and those play groups and the places where they can build trust and relationships and learn from other parents is very useful. And we use those opportunities to give information session and raise awareness for families around what's the best referral pathways. Sometimes there is a lot of resistance to attend appointments because they don't understand what it is. They don't have the trust with different health professionals. So that's where your case manager, and in this case, I imagine they would be still attached to the early settlement, like humanitarian settlement program, and would have a case manager. So the expectation would be that case manager doing that soft entry introduction and explaining what these appointments are for and how it will help and benefit the family. If that doesn't happen, then we do know that families can resist support. Again, especially if we're referring to places that are not culturally responsive and they're not understanding the needs from cultural perspective. I think also in terms of and I'll discuss a little bit more, but it's understanding how responsive that health service is going to be. And if it might mean that the case manager needs to have a conversation with the health service first and just explain the situation and ensuring that they'll be able to do it. If not, then searching for the right one is very important. Thanks, Kenny. If I hear, I think we've all kind of reflected on this case and how we might approach it. I'd be really interested to hear from your perspective, I guess, what you think of the approach that we've been discussing, and I guess, either do it's always so challenging to explore these sorts of issues with any parent, but how we might best discuss some of the avenues that we're kind of talking about exploring with Darian's.
With this, we need to be very careful what we are doing and how we are approaching this family. First and foremost, again, it's really important to gain that trust with the family and make sure you are non-judgmental in your care. With the 6-year-old, it's really important to consider, as Amy said, that they've only been here for 2 months. This could be his way of coping. He doesn't know any other way because we already know that he's struggling with language. So we need to be aware of that. We need to discuss with the mother about his behaviors. A lot of 6-year-olds are difficult to deal with, and that does not mean that they have a mental problem or they have issues. This child definitely is thrown into a new country with language difficulties, with a mother who doesn't have maybe lots of time to be with him and give him that attention. As I said earlier in my presentation, it's really important to encourage parents to find time to spend with their children. That little quality time means a lot, and maybe that's all Darren might need to be listened to from school by the mother and everyone else. When it comes to mentioning mental health, this is a really big issue in cultural context. It's a very sensitive issue, and it would be very important for the people looking after this family to know how to approach it. It's a very sensitive place when you say mental issues, mental health in especially many cultures. And so if you start off by telling the mother that your child might have a mental problem, then you might as well just be telling her not to come back to the clinic. So you have to be very careful about that and try to understand that it could not be a mental problem. Do not jump into labeling mental problems to a child maybe who has no mental issues. Make sure that even if you are bringing in this, to mention it and discuss it with the mother properly and make her understand that we're just trying all avenues available to help Darren to cope with being in this country and to cope with the new school. What Keen said, that just being thrown into a playground with 80 children and with lots of lights in a class, for a child who has never seen that, that could be really stressful and traumatic. So we need to introduce this slowly to the mother, slowly to the child, and make sure that she knows there's a lot of help. Make sure that there's places that she can be referred to, people who can come for home visit to help her with the children. She can go to the clinic, she can get as much help as possible. And I would say that the most important thing is to be sensitive around mental health, mentioning to the family at this point.
Thank you, Fahia. And I think as well, I was just thinking some of the really practical advice that Amy covered as well in her presentation, I think would be very much playing on my mind, I think, as I got to know this family and Darian. I think we have a lot of work to do over time, but just to touch on Darian's next visit, he returns for his second visit, and at this point Mum raises a few questions around bedwetting at night. She's really, really worried about this because she said, this just wouldn't happen at home. It's not, it's not appropriate. And also it's costing a lot of money and just not working for the family. There was another issue around tooth decay that was kind of raised at the first visit, and you hadn't had a chance to address that properly. But Mum's really not concerned about that because he had vitamin D as an infant. He's got strong bones, so she's not too worried. I thought, David, just quickly, are you happy just to touch on that question around bedwetting and perhaps just the oral health side of that as well? Would you?
The bedwetting issue and the concern of a mum about Darian's bedwetting is obviously slightly out of sync with the way we practice in an environment like Australia, where we regard bedwetting only to start becoming a problem after 6 years of age. So most of us would not be concerned that there was anything sort of abnormal about bedwetting at this age. But there are practical management issues that you can offer, and for a start, I would encourage, just waterproof covering of the bed, just simple things. The Australian system requires that you get bed alarms, but there is an out with that if it's contraindicated. And I have to say that on the occasions that I've dealt with bedwetting in refugee families, I've used the concept of disrupting the family as a contraindication to the bed alarm. There is no definition of what the contraindication is in the PBS if you're going to progress on to medication later. But there are ways of for example, using the Blue Nurses system to try and train children, bladder training, without having to go down the medication pathway. At this stage, I wouldn't consider medication, and I would keep encouraging the mother that this is not outside of the normal range that we would expect for a child like Darian. With the tooth decay, I think, again, it's only your second visit and it's difficult, but I would delve even further in that second visit into the dietary history, because it looked pretty terrible from a sugar point of view, but also how the sugar is given. You know, does he fall asleep with a bottle of sugary drink? And that's probably one of the worst things you can do to your teeth, and trying to discourage those simple things while you again work on the diet and try and encourage a more appropriate diet for Darian. I'm not sure, and I'm open to correction, someone might know that this sort of diet and dietary sort of approach is culturally specific at all. And I might be wrong, there might be someone who knows better than me, but I would expect an Iranian Kurdish family to be thinking of diet in a similar sort of way to the way we do. So not asking them to diverge massively if we try and get rid of some of the milk and the fruit juice. So we're not actually asking them to change culturally, we're asking them to change habits, which probably have occurred because of circumstance and the way that Darian's been exposed to his refugee journey, I think.
I just wanted to quickly add something to the bedwetting from a trauma point of view, and I think, so this is something we commonly come across all the time after settlement. Kids can regress and there's bedwetting, and so I think that's something else I would be keeping in mind if it's something that comes up, is that can also be an opportunity for some psychoeducation around trauma and the impact and what mum and dad can expect in some of these things, because yes, it's overwhelming and it might start and it's not normal and what do I do? But some of that's really normal, and that's really common with settlement, is new symptoms and new things can appear and things can get worse before they settle. So I just wanted to add that lens to it.
So we, just in the last sort of 10 minutes or so, over time, despite the fact that mum is still known as mum, you have sort of started to develop a bit of a relationship with her. She's looking forward to the birth of her third child, but she does, she has worries about this. She remembers how Darian's behaviour was affected with the birth of Sammy. There's obviously so much going on at the moment. And she's also concerned, I guess, for herself. She's feeling already very isolated, and is actually really enjoying going to English classes and finding that a really beneficial way to sort of meet people. So I guess we were just wondering again, I was going to maybe ask you, Amy or Kenny, if you just have any advice around some of the things we might need to consider for mum, and I guess some of the supports available. Leanne, you've already mentioned some of them already. Kenny or Amy, or do you?
Yeah, sure. I mean, I think one thing also I would add is I actually think it's really positive. The mum's kind of going, I'm excited, firstly, for this new baby, but also she's aware of the impact previously. So I actually think that's really good that we need to kind of focus on as well. I think things that come to my mind, and that's right, everyone's kind of mentioned things as well, but also is in terms of sort of things that we offer. So we often have, at the moment, I think there's 2 women's groups going, that the pure purpose is around social connection and belonging and connecting with kind of not just similar cultural groups but other cultural groups. And I guess from our point of view in those groups, very aware of you know, to get mum engaged, it's useful offering childcare and working out kind of how is it that mum can come to these things, because they are and she is likely to be quite isolated because, you know, TAFE will drop off with a newborn. So I think that's beyond some of the health and making sure that mum's linked in with certain things, and is there play groups and things which Kenny's mentioned that Sammy can access, but also that mum can still have connection. Yeah.
Yeah, so I would mention the same. So again, those community hubs, and there will be ones in Brisbane next year, they've been announced, but really coordinated that approach there. So with the play groups, with the child health nurses, with the maternity health nurses that are all attending that, it's just giving their, in terms of, you know, helping her with that anxiety as she's going to be with her third child. But the other thing that has come as a result of that, we have had a lot of mothers drop out of English classes because of the same thing. So what's happened now is that there's been extra funding in the community hubs to run English classes, and they come with child minding. So the child minding, and that includes babies, so there's extra funding and support for child minding in these English classes, so the children can be there with the mother. So she'll still be able to learn English, she'll be able to take her baby there and also continue that social connection with the families if she can no longer attend TAFE.
Kenny, I was going to say, I think as a GP, again, I was going to come to this later, but that Refugee Health Network Queensland website that I was talking about earlier does again have a child and youth section where again I often, you know, where we've got lots and lots of resources around, you know, play groups and I often use the Raising Children Network website to find information. So again, I think there's lots of information available out there to support us as healthcare providers and educators, and yeah. So guys, we've probably got sort of 5 or 10 minutes. Is there anything that anybody from the audience wanted to ask, or anything that the panel wanted to add in terms of what we've discussed this evening?
Hi everybody, my name is Abby and I'm a community pharmacist. So my question is mostly for the school. So if the school identifies like a potential health issue, whether it's behavioural or psychological or developmental, do they have a direct referral pathway, or do they have to go through the parents or the case manager?
No, we don't have a direct referral pathway. We need to go through the parents. So if it's one of our Education Queensland verified disability categories, we do have clearer pathways. But if it is a health issue, we need to again develop those relationships with the parents and get them to seek support through health providers. But having said that, we're working quite closely with health at the moment, myself and the principal at Durack State School, in order to make those pathways clearer for us, because you know, health is a bit foreign for us as educators as well, the pathways, and so we're working together more with health to break down those barriers and work together so we know more, so we can help the parents, because we're very privileged to have these parents and children in our school for 6 hours, sometimes longer a day, 5 days a week. So we have those good relationships and the parents trust us. So we can help steer them in the right directions. We just need to know what those directions are as well. So we're working pretty hard in that area. Yeah, hopefully that answers.
Can I just add, because I think it was a beautiful question and probably the one that I really had as well. So as a GP, again, often we have parents come in to see us and they say, you know, there's been problems at school, you know, and we've come to you, I guess, as a GP for help and guidance around that, and to help facilitate, I guess, a referral pathway if there needs to be one. And I guess I would have, having been fortunate enough to have you sitting right next to me, is that I guess I'd like to know what we as GPs or nurses in primary care can do to really enable that to happen better, I guess, from your perspective.
We're really fortunate. We're in Inala, and we're really fortunate that we cultivate close relationships with not as much GPs, but Inala Community Health and very much the Indigenous Community Health, and forging relationships with the Marta Refugee Complex Care Centre. So we're really trying to do that. At the moment, we ask our parents if we can come along with them, and a lot of our parents trust us to come along, and I've got staff going all over the place. Not so much GPs, we sort of haven't got into that area at the moment, but more into your specialised care, and so we're now come armed with pieces of paper and reports and that sort of thing, because the parents, you know, they don't know what they don't know, and so we try and help them as much as we can. And it's getting much easier to get parents to say, yes, we can talk to one another. And so then we make sure that we stay in contact as much as we can. But we would like that to be wider, obviously.
It's really building that trust and communication again, I think, for here. Is there anything else anyone wanted to ask before we finish up? Yeah.
Lee from Oral Health, I think all the panel members touched on it, but I think from Oral Health perspective, we really would love to see the children as young as possible to get that dental home. So I know they'd be referred in from some other avenue, but the big messages of really drinking tap water, you know, reassuring the family that our water is safe and clean to drink, where they might not have had that in their home country, is a really big message. And, you know, mum's having another baby, maybe breastfeeding might be really supported this time, and not to have the bottle, so maybe go straight from the breast onto the cup and avoid that bottle. So all those little things pieced together a really good, healthy oral health message for us. But yes, early as possible, and we take on all the children, so, you know, get that dental home early. Thank you.
Can I ask a question? Can I just ask a question of all of the panel members? If they had one thing they could fix right now about the intersection between health and education, what would that be? Just one thing.
That would make it better. Simple question. Anybody want to start? David, I've had this conversation with you.
I think it's got to be, sorry I'm harping, but, you know, functional assessment. I think if our government accepted functional problems, I think we would cure a whole lot of problems. But if I had a magic wand, I wouldn't have any low self-esteem in the school. We wouldn't even have Donald Trump.
I just wanted to reinforce that as well, and the idea that you have a functional impairment at this point in your life doesn't mean you've got a functional impairment of this level for the rest of your life, and a system that's able to move as a child adjusts and changes as well. So, and away from the idea that you've got a diagnosis and you've got a diagnosis for life. That would be so nice, and it goes both ways.
I'll add something different, because I agree with those, but also probably just a willingness to communicate with each other, and an awareness of what's out there, and an openness to collaborating.
I could just think of it as context within the family unit and their previous experiences and the sorts of supports that they're getting moving forward, so we can help just make really give them the information so they can empower themselves, you know, so there's a really positive trajectory forward.
I was going for Amy's one, communication. I think communication is a big one. If the health professionals in the school should be able to communicate, and also the follow-up. The schools could be able to follow up with the health professionals through the parents, of course, if they're getting the necessary help, and if they went only for one appointment and never went back again, and what's going on.
I think in terms of my experience, and probably more our AT, but is from health assessment to intervention, and the length of time that does impact in terms of education awareness and understanding of how important it is when a referral can take 6 months or an intervention can take a year or two. And I know that impacts a child when they're already in school and they're already learning and they've got developmental delays and they're not getting that opportunity. So I think there's still some broken system navigation there, and it's difficult for community services to navigate, I couldn't imagine, for our families.
I think that we all want the best for our families, so I think that sort of trust and relationships are there because we've got a common goal. I think I would, if I had a magic wand, it would be around dialogue and knowledge, because the more we talk, the more we interact with one another, the more knowledge that we gain, and the more knowledge that then from school land we can help the parents navigate through as well, and all be on the same page, because I know I'm going to walk out of here with so much more knowledge that I didn't know when I came here this evening.
And again, for me, it would be communication as well, I think, between all the services. For the parents, it's just so overwhelming. Every migrant family, every refugee family that comes into the school comes with a different story. And each child, even within each family, comes with a different set of issues. So communicating with both the parents, with medical, with our staff would help, I think.
Thank you all. I think that was a beautiful question to finish up with. Thank you, Janata. Yeah. So if you could just thank all of our panel members again. I suspect Elham has been giving out evaluations as we've been speaking. So thank you all for your time again tonight. Just again, if you haven't signed up for the Refugee Network Queensland e-health newsletter, it's just a wealth of information, and again the website's a wonderful resource, and all of our education sessions are available on that as well. So thank you all. Thank you.